Hello, good afternoon, everyone.
Hi, good afternoon.
Hi, I'm Sushi from the Center for Medical Education. So welcome to our Prime sessions, okay? The first Prime session for the year of 2026. So today we have two speakers. Before we introduce the speakers, just want to share with you a little bit about this session. So Prime stands for Priority Research in Medical Education, and we have this session every first Monday of the month. So this session is actually to support all the young scholars or experienced scholars or experts who wish to share your thoughts or who wish to share your research in this platform and to get feedback. Even though you don't have a so-called completed research, okay, you have a research in planning, you could also share your research in this platform. So please allow me to introduce the first speakers of this month. We have Miss Anuradha Rathnayake. Hopefully I
Yeah,
pronounce your name correctly.
it's okay, it's
Yeah.
okay.
So Miss Rathnayake is a skilled nurse and lecturer from the Faculty of Allied Health Sciences, University of Peradeniya, with over 9 years of experience in clinical practice and nursing education. Her expertise include teaching and learning of communication skills, clinical assessment, nursing education, and developing innovative teaching and learning strategy. So today, Ms. Ranayake is going to share with us her studies on investigating the potential for introducing peer assessment in nursing. Over to you, Ms. Ranayake.
Thank you very much, ma'am, for the nice introduction. And thank you. Let me share my slides. Yeah, hope you can see.
Yes. Oh, okay. All right. We
Okay.
can see. Yeah.
So, good morning, all. So, we are going to discuss about the potentials of introducing the peer-assisted learning for the nursing education. I'm Anuradha RATHNAYAKE, Senior Lecturer from the Department of Nursing, Faculty of Allied Health Sciences and the Sciences of University of Peradeniya. Actually, this was my postgraduate study supervised by the Faculty of Medicine, Professor Kozala Marabe and Professor Deepthi Edusuriya. Actually, this is a collaborative work mainly by we three. When it comes to the peer assessment, okay, let me share the slides. Yeah. So first of all, we will go through what is the peer assisted learning is. So we all know that the peer assisted learning is a form of learning. The way we are learning and the people learn from similar social groups. In a university, we all know the undergrads come in the same age groups, but they are not professional teachers. So they are helping each others while them when they are learning. And the peer assessment is the one form of peer assisted learning. So during the peer assisted learning, the knowledge and the skills are transferring through the peers. When we are discussing about the peer assisted learning and the nursing, so we all know that the nursing is a practical based discipline. So, in the hospitals, we are expecting our students to demonstrate the theoretical skills that we teach in our universities. In the universities, we are teaching the skills and the students are demonstrating those skills at the hospitals. So, they are sharing the knowledge, skills, and the peers is essential. In the nursing education, all three learning domains are strive cognitive domain, psychomotor domain, and the affective domain. So, therefore, in the nursing education, workplace based assessment and the continuous assessment is essential for the feedback for the development of the skills among the students. And now let's discuss about why we need the peer assessment in the resource limited setting. So we all know that the Sri Lanka is a developing country. And we have started the nursing degrees 10 years ago. Before that, we have the diploma programs. And literature has justified the Sri Lankan nursing curriculum needed to be developed with the student-centered learning and the lifelong learning. And when students are practicing their clinical skills at the hospitals, so they are studying with the informal learning incidences. They are learning with the observing, retaining knowledge, and replicating the behaviors with the educational experiences they made, which improve their personal maturity, emotions, and the social development among the peer groups. However, when we are thinking about these informal educational experiences, so they need to be formal to make the formal education. And collaborative learning during the clinical practice may be going to help with the learner empowerment and the accomplishment. When we are discussing about the educational value of the peer assessment, so mainly the ideas of the John Dewey is important. The John Dewey is telling about the learning among students not only happen with the interaction of the lecturer. Learning is not only by the lecturer, students are learning by themselves. And the learning happens through the interactions, maybe with the peers, maybe with the nurses at the hospital, maybe with the doctors at the hospital, and with the environment. And learning beyond the teacher's interaction is a known phenomena of the education. Other than the discussion by the John Dewey, the Tropin is also the one of the key figure that is discussing about the peer-assisted learning. He is telling about arrangement where the individuals assess the quality, level and the amount of success and the achievement of learning outcomes through the colleges. So the Tropin is telling about the achievement of the learning outcome through the colleagues is a peer-assisted learning. And one of the key researchers in the 2010, Guylan is telling about there are two main goals of the peer assessment. The peer assessment, he is telling that the peer assessment can be taken as the learning tool as well as the assessment tool. When the students are assessing each other, it can be used as the assessment tool. And when the peer student and the peer teacher share in their feedback after the procedure, this can be taken as the learning tool. And the other one is, other main idea is discussed by the Sandwall 2014. And there is highlighting about the content learning. So by interacting among the each peer teacher and the peer student, he is highlighting the content learning is happening. And internalization of the content is help to improve the self-awareness, critical abilities, and the judgmental skills. When we are thinking about the theories underlying the peer assessment, two main theories are important. Social constructivism theory by the Vygotsky in 1978 and the social learning theory by the Bandura. Both learning theories are discussing about the learning depend on the collaboration with each other and the interaction with each other. And the cognitive functions that result from the social interactions are accommodating for the integration and the learning. Then, what we did at our faculty. So this research was conducted at the Faculty of Allied Health Sciences, Department of Nursing, among the second and the third years of nursing undergraduates. So in our second year, we are having the 40 students. In our third year, we are having the around 45 students. So we did this intervention in the Faculty of Allied Health Sciences, Department of Nursing. First of all, we have developed and validate for the checklist and as well as the rating criteria for the blood drawing and the IV administration, for the peer assessment and the teacher assessment. The same criteria and the same checklist was used by the both peers and the teachers for the procedures. So therefore, one criteria and the one checklist for the blood drawing and one criteria and one checklist for the IV administration was developed. Then, after development of these criteria and the checklist, student was introduced by these criteria and the teachers were introduced by these criteria. After the introduction, so when the students are at the clinical settings, they were asked to perform the blood drawing while two peers and the two teachers were observing their performances at the same time. Same thing happened for the IV administration also. With the two peers, where the student is performing the procedures, two peers was observing and two teachers was observing. So we completed the IV administration procedures and then we came, after 3 months of IV administration, the same set of students were taken for the blood withdrawing procedures. So we have selected the blood withdrawing and the IV administration procedure because the steps are somewhat similar in each other. And the other one is, all the nurses are expected to master in the blood withdrawing and the IV administration. After the interventions, so we have conducted the qualitative, semi-structured interviews among nursing undergraduates who have participated with the intervention and the nursing teachers. So this was the diagram which shows about the arrangement of the peers and the teachers. And these are the specific findings after the interventions. For the IV administration procedure, finalized teacher score, mean of the teacher score is the 53.63. And for the peer assessment, it was 79.25. And the p-value was 0.02. And for the blood withdrawing procedure, mean value for the teacher score was 51. And mean value for the peer score was 63. And p-value was 0.1. Then after that, we have conducted the qualitative interviews. So throughout these interventions, we have noticed several benefits are there. The benefits are not only for the academic, they are the improvement of the soft skills also. So these were the major areas that we have identified. The first one is the development of the metacognitive skills. The students has developed the communication skills, observing and the reflecting skills, self-evaluation and the self-criticism skills has been improved among the students. And once they are serving as the peer teachers and the peer learners, they have improved the self-monitoring and the self-regulation skills, which was highly contribute their professional growth. And these opportunity for the reflection and the use of the evidence-based practice has helped for the lifelong learning. When they are becoming the peer teachers and the peer learners, they have improved the responsibility skills and the sense of autonomy was there. Therefore, the students were able to improve their clinical skills and to become the initial step for the staff nurses. Other than the academic skills, so these were some findings on the quotations which were taken from these qualitative interviews. So they have developed the empathy and the insights. Look, the students are telling about. We understand that friends forget to perform steps mistakenly. We can get idea regarding the level of knowledge about our friend and reason why he had missed the perform. Students developing the empathy toward the other students and they improve the sense of insight that the same mistake can be done by themselves also. And other one is the by being a peer teacher and the being a peer students help to improve the mutual respect among the study groups. Once the other friends are making mistakes, those points were addressed in the friendly manner. And one of the major things that the students was highlighting was this peer assessment is a less stressful activity. Stress is less than being observed by the teacher. However, there were some challenges that we have faced during the interventions also. One of the main thing is unreliability. So we all know in a study groups, we are having the students with the different levels of knowledge with the different grades. Some students are having the prejudgment and they are thinking that the feedback received from the teachers are more beneficial than the peers. Some students are somewhat reluctant to be judged by their peers and to accept their feedback. So there can be issues among the friends by giving and the receiving the feedback. When I feel that I'm doing practical than my peer teacher, usually the confusion comes to my mind. So I review again before accepting comment from my friends. Look, so sometimes the students become concerned and confused about the peer teacher feedback. And other one is, so when we are doing the process, one of the major things that we have experienced is they were complaining about they were being overwhelmed. So they were telling about, it's not a stress, but this feel like an additional responsibility for us. It's a different feeling like that we are bound to do it correctly. And some are telling about that we have not learned how to mark the procedure. So this has become the additional overwhelm and the responsibility for the students. And the other one is this procedure can be time consuming, maybe challenging and stressful for the students sometimes, increasing the workload of the academia, staff, students and the hospital people. So these were the challenging things. And the other thing is, students were not familiar with the receiving and the delivering of the feedback. Therefore, to address that issue, we thought about we have to allocate the considerable time for the support and the adjustment. And comfortable environment for the safe progress. And the other main thing is training for the students for their feedback. And while we are going through the process, there were positive things that we have noted, and there were some constraint and the challenges that we have noted. For this constraint, so these are the remedial measures for the effective implementations. So, to make the informal learning for the formal peer assessment, outlining of the preset criteria, and increasing understanding for the standards, which may help to improve the validity and the reliability. And pre-validated rubric, which is transparent and the consistent, needed to be developed. And bias of the procedure can be reduced by the clear criteria. And the bias among the students can be minimized by the teacher-mediated peer groups. And once the students are delivering the feedback, it can be done in front of the teacher. And the teacher can be deliver the feedback for the feedback. So the feedback to the feedback method was introduced after the peer assessment. And the scores that we received from the peer assessment and the teacher assessment. From our intervention is discussing about the peer assessment. Teacher assessment cannot be replaced by the peer assessment, but even though that this is having benefits. Therefore, the peer assessment cannot be taken as the part of the summative assessment, but the peer assessment is really nice when you are taking as the formative assessment. And for the effective implementation of these resources are essential. So we can introduce this peer assessment activity at the demonstration room and can be start from the early years of the education, which make them as a habit. And this was the one area that the students were highlighting. So most of the time they were highlighting about doing peer assessment with the pre-notification will not be effective. It's better if we can evaluate others' procedure without informing and to be evaluated without being informed. Look, they are highlighting the importance of the blind assessment. And the students are mentioning about these can be combined with the other assessment method. So they're telling about, I feel like individual capacity is critical to consider. Self-evaluation can be different from each other student's comment. So it would be nice if this can be combined with other methods. And some students,
will you be
some
able
students
to,
are highlighting about the video recording and the playback. And they are highlighting. So if they can record the procedure, if they can play back at the demonstration room, they can give the feedback for the others. And the other one they were highlighting about. So these, when we are asking our student to write the traditional reflective diaries of the self-assessment, when we are sending them for the clinicals, we can ask them to write about their peer assessment experiences also. So, among our procedure, among our interventions, we had come up with the many positive things, and there was some challenges was there. But after all, this is our take-home message. Collaborative teaching and learning approach benefited for the healthcare education. And the formal peer assessment is benefited for the self-directed lifelong learning. 2. Practical implication. Faculty mediation is essential for the improving. So this is the take-home message. And these are the references that I use to prepare the presentations. And I like to acknowledge my supervisors, Professor Kozala Marabe, Head Department of Medical Education, Faculty of Medicine, University of Peradeniya, and Professor Deepthi Eduzuriya, Head Department of Forensic Medicine, Faculty of Medicine, University of Peradeniya. So thank you very much. And we three were the research group. And thank you.
Thank
This is my
you.
presentation. Thank you very much.
Thank you. Thank you for Miss Ranayake for your presentation. Sorry I
Okay.
interrupted just now because of the time constraint.
Yeah, thank you.
Yeah. So we will take a couple of questions if you
Sure.
have. Yeah. So please do put in your question into the chat group if you have any.
Yeah.
While we are waiting for our participants here to put in their questions, I have one or two questions for you, Miss Ranayake.
Thank
It,
you.
there is a slide that you mentioned, you have gathered qualitative feedback, and then you saw that there's a development of metacognition skills, improved self-monitoring and self-regulation.
Yeah.
There's a development, you see development of lifelong learning and improving of clinical skill. Can you share with us which data or data point showing that there is a development of these skills, because these skills are definitely important not only for nursing students but also for medical students or any of the health professional. Yeah.
Maybe this slide.
Yes,
Ma'am, are
yes,
you
correct.
referring to this one?
Yes, yes, yes.
Yeah. So this was the procedure. After intervention, we did the qualitative interviews with
Mm-hmm.
separately with the students, with the teachers, and the qualitative interviews were done based on the two methods by semi-structured and the focus group.
Mm-hmm.
So by making the themes, then these all the data was transcribed
Ah,
and theme analysis was conducted.
I see. Okay.
Yeah, after that, these were the like major areas which were taken from the themes.
Okay. So it's a self-claim kind of things from the qualitative feedback that you have
Yeah,
gathered.
most of
I
the
see.
things was taken from the qualitative feedbacks.
I see. All right. All right. I really like the take-home message that you shared just now, because one of my
Okay.
questions is peer-assisted learning definitely is also not sufficient. So there would be
Yeah,
faculty mediation, which is very important to
pra-
improve clinical
practical
skills.
application.
Yes, correct. So can you share a little bit more about how faculty can actually complement with this peer-assisted learning?
Yeah, yes. So student was mainly highlighting about these peer, like receiving and giving feedback for the other students. And they were highlighting about the some they don't like to receive the feedback some from their friends. And sometimes peer teachers they don't like to give the feedbacks for the other people. So therefore, that we thought about the faculty mediated groups should be there. And the other one was like the peer assessment is not only enough for these the summative assessment method. So
Mm-hmm.
therefore, this can be combined with the other assessment method.
Mm-hmm.
And the other one is,
Mm-hmm.
so if you
So,
can make the rotation, internal rotation to make the examining blinded peer assessment method, it would be nice and it will
mm-hmm.
not harm for the friend circles. And
Mm-hmm.
because some students they're not familiar with the giving and the receiving the feedback directly at the hospital setting, so
Mm-hmm.
therefore we thought about as teachers this process should be introduced from the first year onwards
Yep,
at
yep.
the level of skills lab.
Mm-hmm.
And
Mm-hmm.
like if we can allocate the time from our timetable, it
Mm-hmm.
would be nice for them.
Mm-hmm. Mm-hmm.
This was the main areas.
I see. Okay, thank you. So, the faculty members can actually comes in during the feedback giving. That's very important, as you shared in your outcomes here as well. So there are two more questions that's coming up. First is why do you think that the self-assessment score were higher um
Yes.
in were higher than PA
Yeah.
or TA? Yeah.
Yeah, actually, combining with all those things, we did the self assessment also. And
Mm-hmm.
when we are taking the self assessment in the both procedure for blood withdrawing and the IV
Yeah.
administration, most of the time the students was overrating themselves. So they were
Mm-hmm.
thinking that they were done the skills, but actually when they are referring to the criteria, just after the finishing the procedure, so they
Mm-hmm.
have identified they have not done it correctly.
Mm-hmm.
So this is how we did the self-assessment.
I see.
So,
Okay.
like for the self-assessment, also the same criteria was taken, same checklist and the same rubric. So we use the same rubric for the self-assessment, peer assessment, and the teacher assessment. And all three assessment methods are conducted at the same time at the hospital. Just after the completion of the procedure, either IV or as the blood
Mm-hmm.
withdrawing,
Mm-hmm.
students were asked to fill the self-assessment form within the 5 minutes of time completion of the procedure.
Mm-hmm. Mm-hmm.
So then they remember their steps.
Mm-hmm. I
Then they
see.
got to know that they have overrated.
I see. I see.
Yeah.
Okay. All right. All
And
right. Thank
one
you.
more question is there at the
Yes.
chat box.
Yeah. 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 So did you inform the students about their PE score were higher than the teacher's evaluation? And did you ask them how could have come about during the interview?
Yes, actually, yes. Yeah. So after the intervention, like we had a common discussion at the classroom setting because I'm a teacher there, and I have discussed that their peer assessment scores are much more higher than the teacher evaluation. And most of the thing they were highlighting was they were telling that they don't know how to mark, and sometimes they were having a little bit of a confusion regarding the rubric and the criteria, which we thought about developing more. And other one is, so most of the students they don't like to downgrade their friends. Maybe in the clinical settings, they are going as the friends and the groups, pre-prepared groups, so they don't like to downgrade their friends. And in the interviews, we have discussion. So in the interviews that they were telling about, I still can remember one student has mentioned about
Mm-hmm.
they don't like to lose their friends. So sometimes
Ah.
they are thinking they don't like to lose their friends.
Mm-hmm.
So
Mm-hmm.
sometimes they are thinking that if they give the low score or as the actually score,
Mm-hmm.
their friends will like lose
So.
their friends. They don't like to comment on the like
Mm-hmm.
negative feedbacks because of the friendship issues.
I
That's
see.
why they have suggested the examine blinded peer
Mm-hmm.
assessments are more important,
Yeah.
or else record the procedure and let everyone to comment.
I see. Okay, thank you for your suggestions and the reply for these questions. So, because of time, we'll proceed to the second speakers. Thank you
Okay.
so much for Ms. Rathnayake. If the participants have any questions, I believe they can contact
Yeah,
you
sure.
or put it in the chat so that you can reply them individually.
Yeah.
So I'll pass the chairing of the session for the second speakers to Gillian, my colleague. Dr. Gillian, over to you.
Thank you.
Thank you very much.
Thank
Thank you,
you.
Sushi and Ms. Ranayake. So we'll now move on to our next speaker. So our next speaker is Dr. Sim. He is in the infectious disease department of medicine with Woodlands Hospital. So he will be sharing with us what creates value for trainee doctors in the ward round. So yeah, Dr. Sim, if you could try to share your screen.
Thank you, Gillian, for the introduction. Let me see. I think
Yes.
because the other slides.
Ms.
Yeah.
Ranayake, could you stop sharing your screen, please? Hold on.
Yeah.
Hi, Miss Rathnayake.
Okay, I
Okay, thank you
think
so
that's
much.
okay now. Okay. All right. Can you see my slides?
Yes, we can.
Yeah, we can see.
Okay, great.
Thank
Okay.
you.
So first off, I'd like to thank the organizers from SANMED for this opportunity to share about my research study. So as an internist and infectious diseases physician, I think ward rounds is really something that's very close to my heart. And as a trainee doctor myself, not too long ago, I think this is really a topic that I have a lot to share about. So I really hope I can stick to the 20 minutes that has been allocated to myself. But without further ado, let's move into the discussion today. So these are some of my disclosures, and prior ethics approval had been sought for this study. So before we go into the content, just wanted to outline the discussion for today. So first, I think it's important that we set the context right for this study. So I'll be spending a bit of time to talk about what rounds, some of the existing gaps in the literature, as well as to introduce our research objectives and some of the educational frameworks that we have applied to this study, as that will really set the stage to understand the results that would subsequently follow. And I hope to end off this presentation thereafter by leaving some takeaways for our audience today. And so for what rounds, because I believe our audience today come from varying backgrounds, including a mix of both clinicians and non-clinicians. So it is really important to ensure that we all have a common understanding of what rounds, as it really sets the context and help us understand what would follow through later on. And I would say that even among health professionals and clinicians, there is really very different understanding of what rounds. And it really depends on where you practice. So whether you practice in the inpatient setting in hospitals, where ward rounds are commonplace, or whether you practice in the community setting, where ward rounds may not be that common. It also really depends on who you are and what is your day-to-day job. So as a nurse, as an allied health staff, your perspective of ward rounds may differ from one another, and even among doctors. So surgeons and non-surgeons have very different opinions about ward rounds and how they should be operated. So essentially, if we were to just exclude all these very minute and specialized differences, I'd just like to bring everyone to the fundamentals of ward rounds, which is essentially the backbone of a patient's hospitalization. And it is the primary platform where health professionals, including clinicians, review patients, including gathering the information through history taking, conducting physical examination, looking at clinical charts, and thereafter formulate treatment plans. And it's also an avenue for information to be exchanged between parties. So between physicians to patients through communicating the treatment plans, or whether it's through communication among the health professionals themselves about a particular patient's treatment. And in most contexts, including ours, ward rounds really served as a core activity for trainee doctors. And there has been extensive literature describing ward rounds as learning opportunities. But despite the extensive literature on ward rounds and trainees' experiences with them, there were actually several gaps which we had identified, which we really hope to address through this study. And firstly, we found that actually trainees' experience in ward rounds is very highly variable. And despite it being a core activity, only half of the trainees actually reported that ward rounds were educationally useful. And from personal experience, it can really be a hit or miss at times, and it really depends on who you work with, the medical discipline that you are in at that point in time, where you practice. So that's really very variable, and that's something that we hope to have some consistency in. And while we do know that there are some factors in ward rounds that really improve its value for trainees, such as actively encouraging trainee contributions and structuring time specifically learning, most of these existing studies actually do not employ or deploy a theoretical framework, and that would limit their transferability, which actually results in very isolated findings across studies that do not cohere and do not collectively advance what we already understand about the existing literature. So having identified all these gaps, we want to address this inconsistency and lack of theoretical framework. And we wanted to gain deeper insights into what creates value within the ward round for trainee doctors. And we wanted to understand this through the lens of a theoretical framework, specifically EVT, expectancy value theory, which I will touch on a little bit on further in the next few slides. And by understanding this through the lens of a theoretical framework, it is more likely to generate a more robust theoretical understanding, and that can really help us inform targets for intervention and ultimately enhance and improve trainee motivation. So with regards to expectancy value theory, EVT for short, so it was first developed by Atkinson in the 90s. It was done to really understand the factors driving motivation, which in turn affects decision-making and behavior. And as the name suggests, expectancy value theory, so there is the expectancy component, which is actually how much one expects him or herself to succeed, and the value component, which was simply put, the importance or worth that someone places on the particular task. So for the purpose of this study, because we are looking at the value of ward rounds, we zone in on the value component rather than the expectancy component of it. And while Atkinson first developed it, Wakefield and Eccles later on went on to refine this theory by further highlighting three domains of value, So namely, intrinsic value, utility value, or otherwise known as instrumental value, and lastly, attainment value. And the easiest to understand would probably be intrinsic value, which is really the inherent enjoyment or satisfaction that is gained from engaging in the task itself. So for example, I do a particular task, I really enjoy doing it, and that gives me intrinsic value. Second would be utility value, which is the extent to which a particular task contributes towards accomplishing certain goals. So for example, if this task allows me to achieve a particular aim, then that has some utility value for me. It is of use to me. And lastly, attainment value is actually the fulfillment derived when one can achieve a feat with their own core self schema, social or personal identity. And it between utility and attainment value, because for some, achieving a particular goal may actually be part of fulfilling a sense of self. And so it really depends on how important achieving that goal is to one's identity. And that would be the difference between whether a task is of utility or attainment value. And the differences can sometimes be subtle, but it really depends the extent to which it achieves one or the other. All right, so apart from the three areas of value, Wakefield and Eccles later on went on to expand it further, right? And they included cost in the determination of value. So they actually recognize its impact on motivation. And when they mention cost, it would mean things like an effort cost, opportunity cost, or emotional cost. And in contrast to the three initial domains of value, cost actually creates an intrinsically negative impact. And nonetheless, despite its negative impact, the recent literature has actually highlighted its growing importance in EVT, and with some even proposing to relabel EVT as EV cost theory instead, so expectancy value cost theory instead. And while EVT has had a large literature base in education in general, its specific application in health professions education actually remains relatively limited. And several studies have actually explored how it influences the motivation of medical and nursing staff, as well as the correlation between EVT principles and residency training, but none have, to our knowledge, actually applied the value of ward rounds to trainees. So we felt that by leveraging on EVT's established value domains of intrinsic, attainment, utility, and cost, this study would actually help us gain deeper insights into what creates value within the ward round for these trainee doctors and address a critical gap that is present in our literature. So we adopted the constructivist paradigm for this study, which is aligned with how value to an individual is inherently constructed by themselves and those they live. And through a fully theory-informed inductive approach, we use EVT as an initial lens and sensitizing concept to inform the research question, interview guide, and data analysis, and not so much to use EVT as an endpoint by itself. So we recruited participants from 3 general hospitals under the National University Health System cluster, which is one of 3 regional healthcare clusters in Singapore, serving mainly the western part of our country. And we specifically approached the departments of medicine or surgery because the trainee doctors in these departments were heavily involved in ward rounds, as you know, compared to other departments like radiology or ophthalmology. No offense to any of these clinicians who may be present in the audience today. But because these doctors in the Department of Medicine and Surgery were heavily involved in ward rounds, we felt that they would have richer perspectives about this research question. We define trainee doctors as house officers, medical officers, and junior residents. So these were mainly doctors who were either in the first year after graduation from medical school, or those who have not entered residency training, and those who may have had entered residency training but are considered junior residents, meaning they are usually in the first 3 years of their training. And to focus on just trainee conceptualizations of value, we specifically excluded senior doctors who adopted largely supervisory roles during ward rounds, including consultants and senior residents. We also sought to exclude medical students because their conceptualization of value, especially utility value, was going to be very different from that of trainee doctors due to their differing responsibilities and work expectations. And we purposely sampled participants to try and achieve a diversity of representation across gender, clinical discipline from both medical versus surgical disciplines, residency training status, and the amount of work experience. And this was because we expected value to be influenced by both contextual factors, such as the type of clinical discipline that they are in, and within person factors, due to differing needs and priorities, even amongst trainees themselves. And participation was voluntary throughout. We collected information on the background, such as their place of practice, the specialty of their practice, and the year of training, through an online questionnaire, and all participants who completed the interview received grocery vouchers as a form of appreciation for their time and effort. So we then proceeded to collect data over a 3-month period through semi-structured interviews with individual participants, which allowed us to go in depth and to explore their thought processes. And these interviews were done either in person in a private room or online via a video conferencing software like Zoom. And all interviews were audio recorded with their consent and transcribed eventually with a software Author AI, followed by manual checks by our team to ensure accuracy. All responses were anonymized, and any identifiers unintentionally mentioned were all removed as well during the transcription process. So for this analysis, we conducted reflexive thematic analysis, which was aligned with the constructivist paradigm that we had sought to adopt. And this is also in line with the underlying assumption that value was a social construct. And EVT was used as a starting point to inform our interpretations, and we remain open to where the data took us without imposing EVT itself as a predetermined structure on what we had gathered. And throughout the analytic process, the team documented our evolving interpretations and insights in analytic memos while the coding was being done. And we also met regularly to discuss coding decisions, and this really helped us to improve interpretive depth along the way while the research study was still being conducted. So data analysis and collection were concurrent with the analysis, with each interview conducted actually informing subsequent data collection. And we managed to reach thematic sufficiency after 20 interviews, with teams managing new data without requiring further modifications. So we conducted 3 further interviews after that, and indeed it did not generate significant new insights to what had already been gathered in the first 20 interviews. So because this was a qualitative study, we acknowledged that reflexivity was an important aspect, and we sought to embrace that. So our team included people from different backgrounds. So we had clinicians, we had medical educationalists, and we had a medical student on board. And we really drew out all these different backgrounds. We drew upon all these different backgrounds during the analysis process. During ward rounds, I could provide some sort of contextual relevance and guidance, especially with regards to ward rounds. And the clinician educator among us who had vast experience working with trainees could capitalize on his familiarity with these interactions and medical education theoretical frameworks and try and link them both. The medical educationalist amongst us provided a distinct lens, where her background as a non-clinician actually allowed her to approach the data without any preconceived assumptions that clinicians may sometimes hold about methodologically rigorous engagement with the data. And it was also a deliberate arrangement for the medical student to be involved and to specifically conduct all the interviews. And this was so that the interviewer did not have any position of power or supervisor-supervisee relationship with the interviewees, as compared to if one of the physicians investigators were to conduct it. And so in this way, the interviewees were more likely to speak freely without fear of being subjected to any scrutiny, because if you're supervisee, then they may not say certain things that may appear to be a bit more sensitive. So having outlined the study design and methods, we will now shift our focus to the results. And we interviewed 23 eligible trainee doctors. There was, as we had done purposive sampling, there was almost an equal representation of both the medical and surgical disciplines, as well as members from both genders. Around half of the participants were also in residency training, and the number of work experience would vary from 1 year post-graduation to 10 years post-graduation, with a median of 3 years. And from the data collected, we managed to construct 5 major themes on what creates value to trainee doctors within the ward rounds. So they are, firstly, fulfilling current clinician identity. Secondly, growing towards future clinician identity and aspirations. Third, meeting emotional needs through relatedness. Fourth, helping trainees get on with their work. And fifth, ward rounds incur costs too. So moving on to the first theme, it was about trainees fulfilling their current clinician identity. So trainees valued ward rounds that actually allowed them to fulfill their current identity as doctors. And this was tied closely to a doctor's duty to actually provide clinical care, ensure patient safety, and strive for positive patient outcomes. And for trainees, so ward rounds really offered a tangible way for them to manifest these ideals, which align with why they chose a career in medicine in the first place for many of them. So as you can see from the quotes, when they get to see the patient improve, there is satisfaction knowing that they contributed to that. And if they felt that they don't have the ability to make changes to people's life, then it defeats the purpose of being a physician. And they don't want to do any harm, and they want to be able to provide the best care possible. So another point about fulfilling the trainees' current clinician identity was the recognition that even though they were not in a position to make major decisions during ward rounds, they actually found value in fulfilling essential duties that others could not. And this may sometimes be dealing with small yet important details, such as building rapport with patients and developing an in-depth understanding of them, which in turn would help inform major decisions by the senior clinicians. So, sometimes they found that, they are, when they are playing roles in the team to provide support information, that's okay for what the consultants cannot do. They value add, they don't just receive plans, they help to bounce ideas as well. So for the second theme, it was about trainees growing towards future clinician identity and aspirations. They valued ward rounds which enhance both their clinical competency and autonomy, which were really key to attaining their future identity. So they valued ward rounds that give them some form of autonomy in initial clinical decision making, with subsequent discussion with the senior clinicians and feedback from them, sharpening their competence further. And for many, this autonomy actually arose during the pre-rounding period, which refers to the preparatory work that the trainees actually put in before the ward round. This may sometimes include reviewing charts and overnight events, gathering allied health input, documenting some preliminary notes, and speaking to patients first to make some form of initial assessment. So you can see from the quotes, that when they manage to generate prelim plans and then see how it matches up later with the consultants, that's actually good learning for them. And they over time, when they do more and more pre-rounding, they actually get more confident with the experience gathered. So during ward rounds, they also valued the opportunity to learn from senior clinicians, and specifically, they valued senior clinicians modeling their reasoning processes, making their thought, and those who actually made their thought processes explicit when they justified certain clinical decisions in challenging situations. And they also really valued receiving expert feedback on their performance. And apart from that, trainees also valued ward rounds as a platform for exposure to authentic clinical cases, as well as diverse practices among the senior clinicians. They recognized that these characteristics were important for shaping their own clinical practice in the future, where they could draw on these previous experiences and then which would help inform their practice in the future and help them practice more confidently. So you can see that they valued the real-time teaching on real-time patients that they can't get from textbooks. And as they get more senior, they can assimilate some of these into their own personal styles. So the third theme was about meeting emotional needs of trainees through relatedness. And beyond the sense of professional duty to patients, they actually cherished ward rounds that spoke to their emotional needs. They found these moments, especially those involving social interaction, most meaningful when they could actually genuinely connect with patients and their families and feel the human impact of their care. When they could see firsthand, that their efforts actually brought comfort to someone's life. So you can see that, it's really about these personal aspects of medicine, getting to provide reassurance. They have a feel-good factor. They feel happy when others are happy, and they enjoy talking to people, listening to what their perspective on life is, and all those give them a form of personal. So ward rounds that fostered a strong sense of relatedness, not just with patients, but within the team itself, also help improve morale and emotional well-being. And these are actually valued quite deeply by trainees. And that is because when trainees work closely with other members of the clinical team, if they were supportive and respectful, these relationships actually help ease stress and actually help them feel genuinely connected to one another among their team. And this would help enrich their overall emotional experience. And the fourth theme was about ward rounds, helping trainees get on with their work. And while ward rounds were valued by trainees for their impact on their own professional development, emotional relatedness, and fulfillment, as shown by the earlier three themes, the practical advantages to the trainees' daily work was also very valuable and shouldn't be discounted because they valued ward rounds that actually help them get on with their daily work smoothly, helping them be more efficient and complete tasks on time. And this was really a form of utility value to their daily tasks, and it actually helps them get on with the day's work by helping them clarify clinical plans for the rest of the day, achieve common understanding among different team members, and also help them anticipate and plan for eventualities that may happen along the way during the patient's journey. Lastly, the final theme was really about incurring costs during ward rounds, and I found this the most interesting theme. When conducted inappropriately, actually ward rounds impose significant emotional and psychological costs on trainees, and such costs actually arose, when they lacked psychological safety, when they feared being criticized for certain actions, when they felt unsupported, or when they were very hesitant to ask questions, and this had a negative impact on the value of ward rounds and actually can affect how they perceive ward rounds. All right, so when there are therefore multiple objectives to be met, and therefore when trainees are also faced with competing demands, amongst the finite time and resources that they have, they actually would prioritize and acknowledge, this opportunity costs, and they understand that actually focusing on one aspect may actually come at the expense of another. So excessively long rounds which were conducted actually further challenges and cause physical exhaustion and mental fatigue for them. All right, so having constructed these 5 major themes, there were several key takeaways that I wanted to give the audience. So key takeaway 1 would be that teams, oops, I think I jumped the gun. Okay, let me see. Yeah, okay, yeah. So key takeaway 1, for teams related to fulfilling current and future clinician identities, they will the attainment value domain of EVT, and that was really an affirmation of their sense of core self schema as physicians. So ward rounds which contribute meaningfully to patient care actually allowed them to fulfill their professional duty and reaffirm who they are. And even if they had to execute tasks that initially appeared routine or mundane, such as scribe work or administrative coordination, the value of the ward round was actually recognized when they could understand the downstream impact their actions have on patient care. So it is important that we ensure trainees actually it's important that we actually acknowledge the trainees' contribution and make it known to them and make it explicit, because this actually gives them affirmation and gives them attainment value. Second takeaway was that trainees actually derive value from pre-rounding, provided that pre-rounds are designed and executed appropriately. And this is quite in contrary to what we know from existing literature, where pre-rounding is often frowned upon because it can be perceived as laborious due to potential duplicates in clinical actions, such as asking the same patient the same questions twice or even 3 times, or having to come in early just to pre-round, which actually increases the risk of stress and burnout. But yet this study actually revealed that trainees derive a lot of value from pre-rounding if there is an emphasis on active participation and if they are encouraged to actually independently generate diagnostic hypotheses, apply reasoning, and propose management plans. And this really aligns with the principles of cognitive apprenticeship, where their initial attempts at reasoning are supported through guided participation in authentic clinical tasks. So although there are opportunities rounding, we as educators should strive to find a middle ground and balance generating value with the management of these associated costs. So for example, when faced with a very long ward list, there's going to be a very long list of opportunity costs, and then pre-rounding every single patient may actually be impractical and overwhelming. So educators should try and adapt their practices, perhaps maybe just pre-round newly admitted patients or sick patients. Okay, so takeaway 3. So from an operational perspective, ward rounds enable trainees to progress through the working day more smoothly by providing structure and direction. So clear, non-ambiguous decisions made by senior clinicians during the rounds are actually translated into well-defined, actionable plans. And this actually helps trainees get on with their work. And it is actually a very important forum for them to clarify and anticipate potential problems. So by discussing all these things ahead of time, they are actually better equipped to address these issues and helps them reduce uncertainty and inefficiencies. Okay, so takeaway 4. Okay, coming to the end already, I'm mindful of time. So takeaway 4, while ward rounds actually serve to achieve clinical objectives, their emotional significance for trainees should not be understated. They derive a lot of intrinsic value from the emotional gratification of contributing to patient well-being and engaging in authentic human interactions. So ward rounds that transcend just mere performance of clinical tasks, and if they focus on addressing patient concerns and fostering all these humanistic interactions with patients, they're actually seen as fulfilling and motivating. So senior clinicians should incorporate such dedicated moments and not just focus just on the clinical aspect of ward rounds. So takeaway 5, so second last takeaway, all right, is that all ward round activities have an opportunity cost, which are often overlooked by clinicians. So cost is actually not just a supplementary component of value, right? It's not just one of the 4 domains of value, but In fact, I would argue that it actually permeates all domains of value, and this will actually require trainees to constantly evaluate trade-offs between patient care, administrative duties, and learning during ward rounds. And such an example includes having to decide if addressing a patient's deep-rooted concern in detail is worth the time they lose for expediting the clinical test for another patient, or whether the time spent by the senior clinician to discuss a case for learning purposes is worth the time they lose for their meal breaks or rest. So practically, senior clinicians need to understand that every single activity on the ward rounds have an opportunity cost, and this will become untenable if it becomes excessive, and they must be mindful about balancing them consciously. All right, so last takeaway, all right, is that, and this is probably also one of the most important takeaways that I hope everyone can get from today, is that value can actually be created in various ways. Right, almost every literature about trainees' experience on ward rounds actually describe the learning and educational value. But as you can see through this study, as EVT has actually shown, there are actually multiple domains of value, and it is really not just about educational or learning value for trainees, but in fact there are so many other things such as attainment, utility, and intrinsic value that a ward round can actually provide trainees. And so we can see that EVT has actually provided us with a very useful framework to try and create value, right, and help us design ward rounds in certain ways. All right, so throughout the conduct of this study, there were a few limitations. It was mainly about the scope of the study. While we didn't want to, while we acknowledged that everyone had differing priorities and perspectives, we didn't want to lose our focus, and we mainly focused this time on trainees, but future work could involve the different stakeholders. All right, so I think in the interest of time, I think I've already mentioned a few key takeaways in the earlier slide, so I would just go through this, jump this slide. But I'd just like to spend the last 30 seconds acknowledging my research team, Drs. Matthew Loh, Dr. Lee Hang, as well as Dr. Lee Shuxing, as well as to acknowledge the NUHS Medical Education Distinction Track for the funding received for this study. Otherwise, I think that's the end of my presentation. Happy to take any questions from the floor.
Thank you, Dr. Sim, and congratulations on the completion of the work here. As we are past time, I'll just allow you to perhaps answer the question that is in the Q&A by Prof. Paul Tambiak.
Yeah, okay.
We'll just take this one question. Okay, so I'll read it out.
Yeah.
It does seem like the major benefits of ward rounds relate to learning both technical and social, which are probably best when there is continuity of care. So how did trainees deal with being deployed to other wards at short notice or having to rotate to other stints?
Okay, all right. Thanks, Prof, for the question. So actually, unfortunately, we didn't look specifically into that context, when trainees had to be deployed at short notice, but that's definitely something to consider. Yeah. So I think this time around we went broad. So we basically looked at trainees and their general experiences. We didn't really zone in on the specific postings itself, such as whether they were in surgical disciplines, medical disciplines, or even among medical disciplines. As we know, the different medical subspecialties would have very differing experiences in terms of the ward round. So we didn't go into the extent this time, but that's definitely something that we can look into in the future.
Thank you. So perhaps a future study. So to our participants here, if you have any questions, perhaps if it's okay, you can email Dr. Sim. Yeah, if you have any questions for him. And thank you once again for your presentation. And I would like to hand the time back to Dr. Lee Shuxing. Yeah, back to you, Shuxing.
Thank you, Gillian, and to two of our speakers today, Dr. Sim and Ms. RATHNAYAKE. So thank you so much for everyone for participating in today's Prime session. And for our